in. Today, we will hear 5 presentations and do a quick Q&A after each one. If you have a question, just as a reminder, use that Q&A feature. Without further ado, I'd like to welcome Hanan Foley from MedStar Georgetown University Hospital, who will present her poster or their poster titled All Hands on Deck, Use of Comprehensive Interventions to Reduce VTE Rates in an Academic Medical Center. Hanan, take it away.
Thank you, Gail. And good morning, everyone. My name again is Hanan Foley. I'm the Director of Quality and Safety at MedStar Georgetown University Hospital. And I'm very pleased to present our poster, All Hands on Deck. Okay, next slide, please. Next slide. Venous thromboembolism, VTE, is a serious health complication affecting more than 900,000 people a year in the United States, and it is the leading cause of preventable deaths in the acute care setting. The impact of VTE on the affected patient is of the highest priority. To address this issue and prevent patient harm, we assembled at MedStar Georgetown a multidisciplinary VTE prevention task force comprised of physicians, nurses, quality staff, informaticists, pharmacists, and data analysts. Next slide. Our objectives today are, first, to identify root causes contributing to hospital-acquired VTE rates, to describe the various interventions and changes in practice that were implemented to address these causes, and to identify transferable interventions that may impact processes and outcomes at your own organizations. Next slide. Given the complexity of the problem and the many stakeholders involved, early on, we knew that we needed to adopt a multifaceted approach to quality improvement. Our first step was to create a robust review process. We called it a real-time post-hospital acquired VTE debrief process. As you can tell from this fishbone, many themes emerged, and we were able to nimbly identify many root causes and prioritize action plans accordingly. I cannot go over every one of these root causes, but I'd like to share with you some of them and what we did. Next slide, please. There were many issues related to sequential compression devices. So what did we do? We developed targeted VTE education material, highlighting the importance of wearing these SCDs for a minimum of 18 hours per day. We noticed patients removing them when they move from a bed to a chair. So now they know that they even have to have them while they're sitting on a chair. We ensured that each hospital bed has an SCD machine dedicated to it. This helped reduce the delay in availability of the machines. We also piloted and adopted new comfort sleeves to increase patient compliance with the SCD treatment. We noticed patients removing them, throwing them on the floors, stating they were hot, they were uncomfortable. And we also added SCDs to the anesthesia timeout checklist to ensure pre-induction application. Next slide. There were issues also identified due to missed chemoprophylaxis doses. And the deep dive into this problem helped us identify that these doses were related to patients who underwent procedures during their hospitalization. So we assured that there was increased communication between the proceduralists and the primary teams regarding VTE prophylaxis around the inpatient peri-procedural time. Also, specific electronic power forms were developed. This allowed both the IR, the interventional radiology, and the GI teams to communicate via the electronic medical record and based on the specific service line standards, whether prophylaxis should be held prior to the procedure and when and if to resume. Next slide. As to the issues related to knowledge deficit and lack of data awareness, we provided many interdisciplinary educational sessions, whether in the forms of M&Ms, we had combined surgery, medicine, and nursing M&Ms, grand rounds, specific educational sessions to service lines and nursing. We also developed an intranet site dedicated to VTE. We housed it on our starport under the Quality and Safety tab, and this site provided many educational materials, as well as a link to an interactive dashboard where real-time data is provided by service line, by unit, by provider, and the dashboard also allowed for comparison of the patient safety indicator 12 metrics by like service lines at other academic medical centers. Next slide. So we had a 20-for-20 campaign, a goal of 20% reduction for fiscal year 2020. And I'm happy to report that in fiscal year 20, by end of March, we were able to reduce our VTE rate, all hospital-acquired VTE rate, by 26%. Next slide. Also, we had improved outcomes related to IR procedure, patients who underwent IR procedures and developed VTE. So if we looked at, when we looked at the data between January and October 2019, there were over 1,600 unique inpatients who had an IR procedure. 41 of them had hospital-acquired VTE. That made a rate of 2.5%. Then after we introduced the change between November and December of 2019, there were 349 patients who had IR procedures. 6 of them had hospital-acquired VTE for a rate of 1.72%. This represents a statistically significant 30% reduction. Next slide. Next slide, please. We achieved other improvements in process measures and in outcome measures related to specific service lines. For example, the neurosurgery department achieved 46% reduction. I'd like to refer you to our slide to look at other measures. In conclusion, hospital-acquired VTE rate reduction can be attained through multidisciplinary engagement, collaboration, and consistency of communication. Improvement was not accomplished through one intervention, but through many. This necessitated increased awareness, transparency, and accountability. Implications for your hospitals include identifying your own root causes and personalizing the metrics to empower providers and nursing staff to own their data and make sustainable changes in practice. Thank you.
Thanks, Hanan. That was actually really exciting work. To see the poster with all of the downward trend lines is a nice thing to see. One question we had that came in, you mentioned real-time VTE debrief. Is that something the frontline level staff facilitate, or do other staff in the hospital assist, like your quality staff?
This is a very good question. We worked with the radiology department where they provided alerts to us from the radiology department every time there was a positive DVT or PE study, critical study. So the quality staff were notified of this, and we initiated the discussion with the boots on the grounds. We would review the medical record and go to the unit, speak with the nurses, talk with the physicians, and discuss the whole issue together. And that helped. So the quality department initiated the discussion, but definitely the staff on the floors were involved.
Thanks. I think we have time for maybe one more question. And this one's looking for a little more information. You mentioned education, some of which was sort of, sounds like it was broad-based and more formal. As you're doing the debriefs and new issues are identified, in addition to sort of sharing with the folks who are doing the debrief, how do you circle that back into broader education?
That's a very good question. There was real-time education around the debrief, and that's why we wanted the debrief process to have this educational piece to it. But as we gathered information and as patterns rose to the surface and these themes, we introduced these at the multiple educational sessions that we had. So if we identified issues with the, for example, the 18 hours, that we realized that nurses, physicians, and patients did not know that it had to be 18 hours. So we took this, we developed pamphlets where we went around with specifically mentioning the 18 hours, and we presented it as well at more formal presentations like grand rounds and other sessions.
Right, so a mix of materials and presentation methods too.
Yeah. So there were many methods. This is why the title was a comprehensive approach. It took a multifaceted approach to really achieve the results.
Great, thanks, Hanan. We really appreciate you sharing this. Hopefully others can learn from it and maybe give them some ideas or food for thought on things that they can do to improve their own VTE rate.
Sure.
Thank you so much.
You're welcome.
With